Okay, hello everyone, and welcome to this RCGP webinar on QOF QI entitled How to Undertake a Quality Improvement Project for QOF. My name's Joe Bestford. I am the Senior Project Manager working in the RCGP's Primary Care Quality Improvement team. You'll be familiar to a greater or lesser extent with QOF from the point of view of your day job in general practice, but we're here today to talk about QOF quality improvement, provide you with a bit of an overview of some of the core concepts and principles, and try and bring these to life a little bit with some clinical examples, and look at how you can continuously improve the experience of both staff and patients. So what are you expecting to get out of this session? Well, we'll be addressing the many benefits of quality improvement and the simple tools to support your progress. And we're going to challenge you a little bit to think about how you embed that sort of culture of continuous QI in your practice. In terms of our learning objectives, what we said on the program is that we'll look at how to start a QI project, how to set up a QI project team. We'll be establishing aims and defining measurement criteria and trying to understand what success looks like. We're going to try and recognize and pull out some QI tools and signpost you to them. Some things that you may already use and be familiar with, and others that you may not be so familiar with, and how they may help you. And we're going to just talk about how to sustain new practice and improvements as well, as that's obviously a big challenge. And as I said before, we'll be trying to bring this to life through some clinical examples, just to sort of put it into context for you. So just a bit of housekeeping before we get into it. We are, before I introduce the panel, I should say, we're recording this video. So if you want to go back to it, or if there are colleagues that were unable to attend today's webinar, you'll have a chance to view it. We're going to be focusing first of all on presentations, and then we're going to have a Q&A section in the second half. So to that end, we've disabled the chat function, and we're asking people to send their questions through to the Q&A. And we will be picking up questions in that section and moving through. We're not, I don't think we've disabled the hands up function, but we're not going to be referring to that today. So please don't use that, because we can't see it on our side. If you do have a question about the content, then send it through to the Q&A, and feel free to send those questions through to us at any time, and we'll pick them up in due course. And hopefully we can, by doing that, we can make sure we get the presentation kept to time, and we can get a good Q&A session going as well. If we do run out of time and there are lots of questions, then we'll endeavour to follow up with you offline, and we'll sort of let you know how we'll do that depending on the volume of questions. But yeah, please do send questions through as and when you have them. So just briefly before we get into it, I just wanted to say something about the QOF QI project. That is the project that the RCGP runs. So you are going to be familiar with the QOF QI modules, which are early diagnosis of cancer, care of people with learning disabilities. But QOF QI for us also refers to the project delivered by the RCGP, which is funded by NHS England and Improvement. This is a collaboration with experts from a number of different organisations, which include NHSEI, Health Foundation, NICE, Hull York Medical School, and of course the RCGP as well. The project's been running since I think 2019. It's produced 10 QOF QI modules, company resources, and this year we've been busy producing learning materials and support for the 2 current modules. And there's more general guidance available as well, not to mention the other sort of more general QI guidance that the RCGP has produced through its other initiatives on QI. So for more information, there's 2 links on screen. Easy to find the QOF QI page on the RCGP website, as it's just QOF QI. And we've got the QI Ready portal as well, which is a great resource. And if you are someone who uses social media, then please use the QOF QI hashtag, and you'll be able to search through Twitter using that to find any of the resources that we're promoting through Twitter, our Twitter chats, which I'll say more about towards the end of this webinar, and just any general activity on this topic. So now I've said that, I'm going to hand over to Mike and Liz and ask them to introduce themselves, and I'll start with Mike.
Hi, thanks, Joe. Good evening, everyone. First and foremost, I am a GP. I'm a GP in East London with a special interest in quality improvement. My improvement journey started about 7 years ago, and I was asked to lead a small pilot project in a CCG in London, which taught or engaged GPs in collaborating in quality improvement. From there, I have worked for our local academic health science network, which was known as UCL Partners. So that covers Central London and North East London and its wider footprint. And my role there was to promote and to disseminate and to teach other GPs about quality improvement and its benefits to them and to the practice. I've since undertaken a master's degree in healthcare improvement, and I've been working for the college for the past 2 years with this work, initially with Simon Stockhill, the other national clinical champion for QI, and we've created these 10 QOF modules relating to QI, but also, as Joe mentioned, a whole range of accompanying supportive resources, which we'll allude to a lot during this talk, and we will certainly put them up with the audience notes and online afterwards. I'm very proud to be working with Dr. Liz Glidewell as well. Over to you, Liz.
Thanks, Mike. Hello, everyone. I don't know if you can see me on the screen here. I'm Liz Glidewell. I'm a senior lecturer at Hull York Medical School. My background is an implementation scientist, so I try to conduct research primarily to get evidence into practice for the benefit of patients and to support staff to do that as best they can. I started my QI journey in secondary care and working with a team in Sheffield, York and Leeds to implement shared hemodialysis care, which has had a phenomenal effect on patients, and I'm very proud of that. And tonight I want to continue sharing the tools, techniques and tips that you might find helpful to start your improvement journey if you haven't already started. Back to you, Mike.
Thanks very much. So we were a bit reluctant to start with this slide, but we thought we should, and we can't ignore it, and we will move on to brighter and better things. But we wanted to acknowledge that there are numerous challenges facing general practice at the moment. But with those challenges also comes potential. So I've listed just a few of them on the screen here and talking about both contractual and financial uncertainty, constant changes, and the thing that I think is affecting all of us is the workforce challenges. And of course, the PCN is valiantly working to introduce a whole variety of other roles which can work together with us GPs and practices, and which we wholeheartedly welcome. In addition to that, I suppose technology has advanced, and despite the fact that there was a sort of a temporary drop in patient demand when COVID first started, and we all felt it was an eerie sort of place. My practice was very, very quiet initially, but the phones didn't stop ringing, and the electronic consultation service suddenly went into overdrive. So not only has patient demand sort of rocketed again, but we find the complexity of what comes to us now has grown, and to a degree patient expectation has changed over the past few years too. So we recognise that there's lots of issues making it difficult to deliver improvement, and I've mentioned a few, but there's also demands from other NHS services and NHS agencies. We often find there's a lack of protected time to spend really concentrating on improvement, and I suppose the new QOF QI domains will to some degree allow for that. And there's also a wide range of improvement capability within practices and between practices. So, you know, I would say that we cannot ignore over the last 18 months with COVID sort of taking hold, that practices have adapted incredibly well, and not only sort of taking on new systems. So some practices will never have used electronic consultations, or will have certainly had to change their telephone triage system. And I think this has had to happen at a really rapid, unprecedented pace. Now, on top of that, practices and PCNs have devoted time, efforts, staff, resources to a massive vaccination effort. And without it being formally labelled as QI, practices have been certainly maintaining quality, but improving quality throughout this entire period. So the next slide sort of says, what can QI do for your practice? And I've really just summarised it in that you can, or we can, continuously improve processes and outcomes for not only patients, but for staff as well. Now, probably the difference and the thing that's slightly unique to QI, and what is unique during these QOF QI modules, is if you compare it to previous QOF, where it can be described as it's a tick boxing exercise to a degree. The aim is to improve care throughout, but what the quality improvement's allowing us to do is to really think about which elements are really important to our population. You know, a standard population, 7,000, 10,000 patients, it may well be different to the population to the practice next door, certainly different to the practice in the next CCG. So the QI does provide flexibility and the ability to tailor, whereas perhaps the old QOF didn't. And I thought I'd just share some things that, some feedback from last year. So these QOF modules have now been running for 3 years. This is the 3rd year, despite sort of QOF being suspended along with the quality improvement domain last year. But 2 years ago, when all practices were engaging with the prescribing safety module and the end of life care module, practices said that, some practices replied and said, there was certainly an agreement that many of their processes felt safer and more robust as a result of the QI projects they did. There was a shared sense of satisfaction once those systems had been shored up. Quite candidly, some felt a real element of surprise when they learned of their baseline performance, but that in turn led to real determination to improve things further for their patients. I think empowerment came up on multiple responses to feedback. Empowerment of some of the quieter members of staff, perhaps some of the staff who don't really speak up during clinical or practice meetings, and they were really able to engage and to offer their valid and really quite multidimensional opinions during the QOF work and the QI work. Others, dare I say it, suggested they enjoyed it. Particularly the learning process and mastering a new skill, and others appreciated collaborating more with not just their neighbouring practices but those of their PCN, something that they just realised they weren't doing especially frequently. So I think there are, I mean, that's a smattering about what QI can do for your practice. All of these link in with what's known as the triple aim of healthcare. Now, the triple aim of healthcare was coined by the IHI. Now, that's the Institute of Healthcare Improvement. They're an American outfit. They're based in Boston, Massachusetts. And that sort of triple aim of healthcare can be applied not just in secondary care, but in primary care too. So the diagram here shows that the triple aim sort of consists of trying to improve the health of a population. So that's ultimately trying to improve patient outcomes, but also improving their experience. So a patient's journey from start to finish. In addition to that, for the benefit of being able to treat more patients, probably to a better degree, one has to think about reducing the cost or providing best value for money. And there has actually been a move to changing the triple aim of healthcare, and some organisations now adopt the quadruple aim. And so actually for many organisations, the fourth aim is to attain joy in work, which most people eschew, most people don't think about, most people just get on with it. But actually some organisations, some CCGs and some practices have really tried to focus upon this. And then for other organisations, it's really about balancing. The fourth pillar is now about pursuing health equity. So the triple aim or the quadruple aim. So I suppose the next stage is, how do we do it? What do we do? That's probably why you're on this webinar today. You know that despite being involved in the prescribing safety and end of life care modules 2 years ago, and last year possibly not getting started with the early diagnosis of cancer and the learning disabilities modules, that you're wondering, well, okay, what can I do? What do we actually need to do? So this slide is by far not exhaustive. It's not comprehensive. We've agreed, we intentionally decided to simplify it. This is an introductory summary slide. On the left-hand side, we've split it even further into 3 components: to diagnose, for practices to establish what's feasible, and then to initiate small changes. So above all, I think the key to succeeding in QI work, the key really is to listen first and to try to engage some others, okay? So what we really want is for anybody involved in the QI work to feel like it's worthwhile. This is not intended to just be another tick box exercise. It's not something extra to what you have to do. And that certainly was the ethos. That certainly was the way people used to think about it until very recently. And in fact, some people on this webinar may well feel like that at the moment. But let me reassure you, it's not supposed to be extra. It's supposed to make things easier and improve outcomes. So to boil it down, we want to get everybody on board. We want to work out what's feasible and decide on the first small changes. I won't labour each point here because Liz and I are going to go through each of these in a little more detail. And if you still don't understand it, we will also point you in the right direction in terms of the multitude of resources that are available. So if I can just say that the quality improvement may seem like another language, or certainly some people promote it using a lot of jargon, but it need not be jargonized. We try to talk about it in daily, in terms that we all can understand and appreciate. QI, it's not, or it shouldn't be foreign concepts. I swear we've been doing this directly or even indirectly for years already. But the point is we're trying to offer you an opportunity to make it a little bit more structured, not necessarily robust, but just more structured to have positive outcomes at the end. Okay, next slide.
Okay, I'll take over from here. So how do you go about engaging your team? Well, as Mike said, listening skills are the best thing, really. It's important to identify everybody in your team. QI is often undertaken by limited people, but that's not how it works best. It really is a team sport, and it's all about identifying everybody who's involved in the work. This is a really good chance for you to really appreciate the work that gets done by different people and to really understand where the frustrations are for them as people. It's getting all the people on board in the practice who do the work. So this is regardless of seniority. You need to include all the relevant clinical people like registrars, nurses, physios, pharmacists, healthcare assistants, physician associates and the likes. And you also need to include other people outside of your immediate practice who could help as well, support your endeavours, like various people in the primary care network, health and wellbeing coaches, social prescribers, care coordinators. alongside them, there's also other people that you can learn from, and resources are provided by various relevant third-party organisations. Particularly for these modules, there's Cancer Research UK and Macmillan, to name others. We will provide you with links to all of these individual details. It's really important to get people on board, to identify all the relevant people, and alongside that, at the same time, to start engaging with the relevant patients. Together, if you include all stakeholder views, you can start to use tools like the stakeholder mapping to mark out who is really interested and who has influence and the power to direct resources to help you transform the frustrations and the bottlenecks. So I'll pass back to Mike to give an example. No?
Yeah, thanks. No, sorry, it's yeah. So I suppose there are a variety of ways that you can work out what it is you'd like to focus on. So we were debating just centering this this webinar just around the forthcoming cancer and LD modules, but we sort of felt, well, actually you can apply this to any QI project, but we will touch upon certain examples relative to the ones that are happening this year. So I know it's not easy to read on the screen at the moment. In fact, the next slide is a bit more detailed. So if you go to the next slide, Joe, that'd be ace. In order to sort of, once you've identified which elements of the QOF modules you'd like to focus on, or once you've decided which project you want to focus your QI efforts on, it's certainly sensible to think about using a diagnostic tool. Now, one which you may have used already, one which you may have seen, one which you may have heard of but may not have used already, is mapping your process. Okay, now that does sound like jargon, but certainly you think about when we talk about a process, and the one I put on the screen here is just about handling results. So whether it's going to be as part of your learning disability health check, inevitably your patients are going to need to, to access results, or certainly with the early diagnosis of cancer, this is an example of a process which you can do. So really simply, you would sit down, you would recruit the entire team, you've got them all in a room, you listen to everybody, you ask people to together work through the process about what happens from the second that a patient needs blood test doing to the end point, which is where the results are going to be actioned and fed back to the patient. Now, if you think about that, you think, well, what, there may be 5, 6, 7 steps, but sit down as a team, sit down and listen to every one of your team members, and you'll find that the steps are often, powers more than you may have anticipated, just because you don't really think about things, or because we're on autopilot most of the time. The receptionists maybe, the clinicians maybe, this is the process, this is how it works, when we often don't think about how challenging it along the way. So the utilization of mapping a process is really helpful. So in this example here, the yellow post-it notes are the points along the process journey, and the purple post-it notes are areas where things slow down or things can be improved. You can apply this process mapping to pretty much any process or a system in your practice. But there are other tools available. You don't have to use them, but they are, if you're at a loss, it's worth trying one or some of them out. Fishbone diagrams you may have heard of. They help get to the root of a problem. You have an issue, your process isn't working. Consider just drawing a fish with a spine and some bones, and establishing what the root cause is that way. Some people use audits. So, for instance, I know that maybe 10 or 20% of the population will have used the National Cancer Diagnosis Audit last year. The problem with that is that the results obviously relate to last year, and we know that not all practices are using it. So if you're not going to use the NCDA, you can certainly use one of your other audits that you've already done this year, or actually if you haven't done one, just rattle one off and then utilize that to work out, right, which elements of this do we need to work on.
So just to add to that, Mike, I think that these diagrams are fantastic for identifying any sources of duplication, any wastage in the system, any delays, any unnecessary steps. And they also identify really good sort of touch points where things could only happen, for example, if there's the availability of a particular consultation room, or if a patient requests something, or if it's a particular member of staff is in. And it's really important if you can visualize these and make the map available to people who aren't necessarily able to attend the meeting where you get together to discuss it, and allow people time to add as things come up. You can get a whole team approach and really identify where the frustrations are and where the really easy quick wins are for changing things to make it better for you and your patients. Okay, so one of the great things about quality improvement is that it always involves measurement to know that the change is actually beneficial and isn't adding to the frustrations that you already experience. You can't know if any change is an improvement unless you start with a baseline measure. Sometimes you might think there's a problem, or you might have data from a wider audit that you think is problematic for your practice. But until you start to drill down into your local data in the practice, you don't actually know whether there's room for improvement or how much. And it's really important, even if you identify that there's lots of room for improvement, that you don't get overwhelmed by that and you start really small. There's lots of data that you can use inside your practice. I find it easier to start with any routine data. So this can be clinical data like the examples we'll showcase here, or it can be patient satisfaction data and other types of patient data that's routinely available. Or you can start with improvement conversations to start identifying what it is particularly you should be measuring, and we'll come back to types of measures later on. I think that's over to Mike.
Yeah, thanks, Liz. I agree. I think hopefully this webinar will allow people to think about the different types of data. As Liz said, usually we think about data, we think about numbers, we think about quantitative stuff, but actually the qualitative stuff is as important. In the QOF QI guidance in the modules itself, one of the first things the cancer one suggests, for instance, is looking at and comparing yourself to the Public Health England Fingertips website. Now, it's an absolutely wonderful, brilliant site which has so many advantages, allowing you to compare so many different of your data points, not just to yourself in previous years, but also to your adjacent practices, CCGs, and up and down the country. One of the negatives we have to acknowledge is that the data is not in real time. And even though it's brilliant for producing some benchmark baseline data, it's not the data you're going to use. It's not going to provide the data for the rest of this QI project. Okay, so you need to think about sort of not only looking at external data to set your benchmarks, but then think about collecting data and how you can collect data internally. So some examples which are relevant for the next two modules would be, for instance, to run regular searches using your practice operating system like EMIS or System 1, for instance, to identify the numbers of patients who've had health checks for if they've got learning disability. And that way, once you've agreed on some changes and put those changes into practice, you can then run the same search again and again and again. You can ask an administrator to do that, and then you can continually look at your data in that respect. Similarly with cancer, you can look at, for instance, those patients who have been invited for screening, and those who have attended, and those who've followed up, and those who've refused with informed consent. So all of these are easily searchable, but to some, we appreciate right now, it may be out of your comfort zone, but there's definitely going to be someone in the practice who can either run these searches for you or create these searches. And actually, some of the cancer charities have already written these searches. They are already there. I think Cancer Research UK or Macmillan, they are easily accessible for the following modules.
Okay, so now that you've thought about diagnosing your problem and knowing the scale of the problem that you wish to tackle, the next stage is to think about what are the solutions. And this again comes back to using and listening to the stakeholders that you're working with. Often it can be very simple solutions. People are often frightened of change, and change can be frightening. So what you're looking to do here is to have an evolution, not a revolution of change. You don't want to scare people off, and you don't want to radically alter the system. You want to test very small scale things of change. What you do is you speak to people, you'll find out which practice resources, which case studies on the RCGP toolkit, which toolkits might be relevant to you and that you find helpful. Some people have toolkititis, so that might not work for your practice. The things that I would suggest that you try and avoid where possible is don't just revert to yet another poster. These tend to get lost in practices and become wardrobe furniture. Unfortunately, even though I'm talking to you right now, we know that this sort of lecture style presentation that's very didactic does not work in the long run. So we'll try and make it as interactive as we can in a few minutes. You need to think about really making sure that you've got everybody on board with the problem and that you provide credible evidence to them. Otherwise, they will just discount the data that you show them and they won't get involved in implementing the changes. The other thing to avoid is overly complex interventions. You want, as I said, to focus on evolution, not revolution. And you need to think about what it is that you're actually trying to change. We all know that the solution isn't knowledge. Education doesn't work because clinicians and members of the practice team are all in it for the benefit of patients. Often it's more broader things that happen and that need to be tackled. And through your diagnostic work, you can understand if it's a lack of awareness or if it's a lack of confidence, whether people need a little bit of help to get more motivated to do something differently. You've got to select your intervention according to the barriers that you identify and try and map that on as well as possible. And in some cases, you might use posters or something as part of your intervention if that works for your particular practice. But it's just to be mindful of what you put in the poster. Always pilot your interventions with members of the practice to make sure that where you put the interventions, how they're framed, for example, gets everybody on board and make it a collaborative project. Next slide, please. And it really is about thinking what is feasible and what is the smallest scale change that you can make. You can always add to it once you know the effect of this change isn't harmful. There isn't infinite resources. We can't just employ more staff. We don't have more money. We don't have more resources. So you need to think about not just the resources that are needed in terms of things like IT skills and the funding and so on, and the time involved of various members of staff, but also the effort required to see an impact. And you just need to try and think about the balance of effort to benefit and think about the solution that most staff agree would bring biggest impact to their work. Okay. So when we talked earlier about the Institute for Healthcare Improvement and the triple aims, this is the diagram that they use to help you formulate how you go about your quality improvement project. So we've talked about the first question about what you're trying to accomplish in terms of being a diagnostic phase, using your data, using your stakeholder opinions to try and find out what is it you need to change, and then using your data to try and think through more about what change is feasible and possible. When you then move to the how do we know that change is an improvement, that's when you need to think about your measures and what it is that you're going to put into your run chart, the single thing that you're going to record over time to show whether or not there's an improvement. And we'll come back to run charts in a few moments. And then we'll talk about the changes that you can make. What we want you to get to into the habit of doing all the time is thinking about the planning stage first and foremost. Often this is just done by one person, but this is where the team comes in. You then do the action, and you do a small action. You study the impact of it, and then you act. And that's where you decide whether you're going to adopt the change as effective, adapt it slightly to tailor it more for your practice, or abandon and go back to the planning stage again. Okay. This diagram may look very small on your screen, so you might find it easier to look at it after we've passed the webinar on as a recording. But this is a key message here with Plan, Do, Study, Act cycles. They're very, very small and they're iterative changes. In research, you tend to assume that you've got the right solution and you evaluate it at large scale and then go on to implement it if it's positive findings. But in Plan, Do, Study, Act cycles, you've got the benefit of the fail fast mantra. It's a bit like if you've ever looked at a Google screen. They're continually randomizing you to different formats, and you'll have seen how it's, for those of you who've been around a while, you'll have seen how Google changes all the time. This is what Plan, Do, Study, Act cycles are based on. We start very small, and you decide whether to adopt, adapt, abandon, or try again. You then move on to maybe more patients. So you have started with maybe one clinician or one group, small group of a few patients. You might test it then on a slightly larger group of patients to see whether the impacts are sustained. You then do follow-up tests and continue to refine your interventions if you need it. That then leads to wide-scale tests, and then you hopefully progress to implementation. But a lot of diagrams in QI create the impression that you'll find the right solution first. And that doesn't often happen. It'd be great if it happens to you, and please pass it on as a case study for the RCGP materials. Okay, so this is an example of a run chart that we talked about. A run chart is very simple. You don't need statistics to be able to work it out. The RCGP have a very simple how-to guide. But essentially, all that you're doing is deciding what you're measuring, thinking of an appropriate scale that will show change, and then deciding along the bottom how frequently you can measure your change. So you put the dates along the bottom, and that might be every day, every week, or every month, depending on how long you expect to see change in that particular outcome. So if you were looking at, for example, the impact of change in the telephone call system, you might look at hourly data or daily data. If you wanted to do something more at the patient outcome end of things, obviously these take a lot longer to see changes, and you would need to extend the timelines accordingly. You really want these changes to be visible and to be able to publish them to all the people who you're working with as stakeholders so that they can begin to see change. There are rules to be able to help you identify when change is relevant and when it could be caused by random variation, but we're not going to go into those tonight. Those are more advanced skills, but I hope that you can see along here that there's a red line indicating where practice normally exists. That's the median line of performance. And over time, you can see that the dots go above and below the line, indicating changes in performance. If we were working on this run chart together, we'd start to annotate it with things like holidays and staff shortages and things to understand where these peaks and troughs occur randomly. And then we can begin to see, also plot where our interventions occur. So you can see if a change is down to your particular intervention or not. Okay. Mike, did you have an example here?
So yeah, this is an example, I think, which we've published on the college website. I think it's rather similar to what Liz mentioned. There are, in this case, there's a set of data points. You can see that each of the points sort of is either just above or just below that median line, the average line. So hopefully you can see from this run chart here that if there have been any interventions that have been made, they haven't really made a difference. So this is a nice sort of steady state process that's going on. You can imagine that actually if you did make a change and it helped, then you would see a real sort of a deviation from that median line, depending on the intervention that you made. So run charts, again, they're not the only way to sort of portray your progress, but they are really helpful, particularly if you're able to quantify your changes. And to be honest, a lot of the aims and objectives of the QI QOF modules, they usually can be counted. And there's a lot of evidence to say that people respond really well to seeing visual summaries. And they certainly do sort of continue to sort of not motivate teams, but to maintain enthusiasm when you can either see when you can see progress, whether it's positive or negative. So I'd like to talk. That's 40 minutes done there. So that's a real whistle-stop tour, and I just wanted to summarise what we discussed already. We said it's not exhaustive. This webinar was not supposed to be ultra comprehensive. It's hopefully it's really going to be a good direction for taking the next step with your QOF QI projects. The benefits, as we said, they ultimately should improve the patient outcome down the line, but we recognise that 12 months per project may not result in humongous changes in patient outcome. However, 12 months is certainly long enough to make a change in the understanding of the practice in how quality improvement works. It also is certainly long enough to make a significant change in a process or in a number of processes that can and probably will result in patient outcome improvement further down the line. So please don't be disheartened that each of these QI modules is only 12 months long at the moment. We may find that they last longer in future. If it doesn't seem apparent at the moment, then in addition to the benefits of patient outcome improvements and hopefully an improvement in the patient journey, think also about how this can make, to be frank, your practice staff's lives easier, more harmonious, less chaotic, less problematic if processes and systems are shored up to a degree. So the other things I'd like to say are, and I think Joe alluded to them earlier, that if you're not ultra confident in quality improvement at the moment, then there is a whole range of resources which we will add to the website and with the audience notes to this. So if you're not if you didn't feel capable prior to this webinar, and now you do, that's really excellent. We've done our job. But I would certainly say, look at your neighbour, look at your adjacent practice, look at your practices within the PCN. There's bound to be one or many or a few practices who've really got this, who've grasped this, that would be able to sort of help you along the way. There are additional sort of people resources from the college. So I'm one of the national clinical champions for QI, but there are also over 30 regional clinical QI champions who are willing and able to be communicated with or contacted, and we'll also promote that for you. Outside of the college, there is the Q community. I think Q stands for quality. I hope that's apparent. And the Q community is a community of like-minded healthcare professionals, so primary care and secondary care, clinicians and administrators and managers, all with an interest in quality improvement. It's a very easy to access group, and there are numerous discussion groups, forums, projects going on as we speak. And I suppose it's probably pertinent just to remind people that the Royal College does have its QI QOF hub and the QI Ready web pages. If you're already sort of feeling confident, it may be worth looking at the the Health Foundation website. They've got a great quality improvement made simple document and other resources. And in addition, sort of further up north, NHS Education Scotland have produced some incredible resources relating to QI, right from beginner level to sort of people who've done it and feel relatively confident, all the way up to expert level. But we'll publish these as well. Okay, I think, Joe, we're gonna go over to Q&A.
Yes, if I remember to unmute myself. So stop sharing those slides so you get a better look at us. We've got one question so far. So just before we get into that, I just want to encourage people to send their questions in. We've got a good 10 minutes, so this is a great opportunity to engage now. So we've got the first question, and it's actually really a two-parter from Iramnaz Adam. So thank you for that. So the question is, how do you measure that the improvement has worked? And are there specifics that would indicate early on that the outcomes are desired or not?
Will I start with that one?
Go ahead. Yeah.
Okay. So I would thoroughly recommend the two approaches to it. One is to keep talking to people during and at the end of each improvement cycle, getting qualitative feedback from the people that have been involved in doing the work or experiencing the clinical changes will be really valuable feedback. The second one is to use your run charts and to use them in two different ways. One is to look at the outcome that you're particularly interested in, the desired change that you're looking for. But the great thing about quality improvement, unlike research, is that it also encourages you to measure something called a balancing measure as well. So these are trying to capture the unintended consequences from your intervention as well. So when you try to think about making a change, it's really important that you don't keep adding to an already overloaded system. What you're trying to do is look at what you can take off the agenda of people and then make a very small change that will benefit them without adding additional work. But sometimes we don't know the impact of an intervention until we try it on the ground. So talking to your stakeholders and thinking about what appropriate balance measures would be as well that you can take on board. They might also suggest halo effects as well. For example, elements of care that also improve because of the area that you're working in. For example, if you get everybody working on the same checklist, for example, it could improve your QOF data capture of other outcomes of interest as well. So that would be my suggestions to start with.
And what was the second element, Joe?
The second element was any specifics that would indicate early on that the outcomes are desired or not?
I think Liz is part answered that second part. So I suppose, as we say, talking to everybody involved, and can I just highlight something which I'm not sure we emphasized enough during the the slides, which is if you haven't already thought about including patients in your improvement plans, then absolutely do. Think about the sort of the richness of what you can get in terms of identifying what's important to them. So when I say speaking to colleagues, speaking to the stakeholders, if things feel edgy, dodgy, I suppose it's a really not necessarily a red flag, but a good opportunity to perhaps study what you're doing a little sooner. The other thing I would say is if you're going to just monitor the data, so ignore the ability to speak to friends, colleagues, etc., then you might find that you're not getting the desired outcome early on. But I wouldn't say necessarily completely ignore that. I would look at your data, which is not gone the right way, and utilize that, really scrutinize it to say, okay, what do we think's happened here? And usually once you sit down, once you identify this, it becomes apparent. So combination of qualitative, quantitative. Part of me says don't give up. Part of me says if you don't get the data you want initially, don't give up, but there's probably something you can tweak in order to see things going in the right direction.
Great, and we've got another question through from an anonymous attendee. So thank you, anonymous. They ask, hi, thank you for the talk. I was wondering, have you ever used protocols in QIP design, in brackets system 1? For example, automated reminders for patients based on searches, book an appointment for your CS screen. What were your experiences? Any difficulties?
I can start again. Yes, I've used them not in a QI project particularly, but in a research project in primary care. And it was part of 2 randomized control trials that were conducted by Robbie Foy, the professor in primary care at the University of Leeds. And we implemented the System 1 protocols for trying to manage risky prescribing in primary care. And they had very mixed results in our process evaluation. So just to showcase 2 examples, one practice hated them and switched them off. A bit like toolkititis, protocols can sometimes appear at the wrong time to the wrong people. The other example was of a practice that found them immensely beneficial because they enabled the prompts for their administrative staff. And when a repeat prescription for an opioid came in for longer than the desired duration, the administrative team sent a note to the prescribing GP as a reminder. And that worked very effectively for those practices. And we know that automating the searches for patients and being able to tailor your searches, I think the challenge is that the clinical language in the electronic health system is often very duplicated and laborious. We found 73 different codes across West Yorkshire for smoking status, which you'd think would really be yes, no, or former, but this just goes to show you that creating protocols can be quite challenging to get it right. But if you do get it right and you get the timing, the frequency, and the content message of them right, by working with your stakeholders, they can really benefit your practice, and they can deal with the problem of memory being a problem to do the right thing.
Great. Mike, do you have anything to add on that, or should we?
Thoroughly agreed.
Great.
London is predominantly EMIS, but it does come up, the protocols, the prompts, the concepts, they do come up on a regular basis. It's something that people, their individual practices often come to when they're creating their change ideas. But you'll find that those who don't come up with those suggestions, obviously the practices who may have tried and failed in the past, or who aren't necessarily IT savvy. So it's definitely worth, at the PCN meetings, if you're so particularly pertaining to these QI and QOF modules at the PCN meetings, listening to your colleagues and just taking no suggestion, I'd say, is a bad suggestion. People can often listen to suggestions and give you feedback. They can edit, adapt. They can make them better, stronger, different. But often the feedback we found from the very first QOF QI modules were that the PCN meetings were perhaps underutilized by some practices because they felt too shy to put their suggestions forward.
Okay, great. We're actually getting really close to time, and I'm conscious that people want to go off and get their tea. And we actually have more questions. I did have some sort of questions lined up that we put out on Twitter in one of our Twitter chats. So I think some of these are going to have to roll over into our next webinar. So I'm just going to sort of close things out now and basically say thank you to Mike and Liz for taking us through that, and for everyone for attending. We're going to be in touch after this webinar with an email, just with an evaluation questionnaire. We really appreciate if you can just take the time to respond to that. Help us understand if we got the content right and pitched it at the right level, and help us tailor things going forward, because this is the first series of webinars for QOF QI. And yeah, we just really greatly appreciate the feedback, unsurprisingly. Just a few plugs as well. As I mentioned, we've got a lot of activity in the next few months, so a few weeks, I should say. So we've got, if you want to dig a bit deeper into QOF QI, we've got a webinar on each of the modules, so one for LD and one for cancer. And we'll send the dates around as well when we get in touch with you. And we'll basically have a bit more time in those sessions to go a little bit further into the sort of clinical side, but obviously keep the sort of that QOF QI quality improvement context going. And we've also got a webinar on quality improvement at the PCN level, and looking ahead to sort of different sort of models of general practice and how we carry out quality improvement. We also, in the next few days, will have some podcasts on cancer and LD going live. So you'll be able to find them by going to wherever you get your podcasts from and searching for RCGP, and they should pop up. They're more of a sort of an overview. So if you like what you hear on that, then I think it's still worthwhile for you to come along to the webinar. And again, we'll make sure that there's time for questions. So there's a bit of engagement as well. We also, as I mentioned, are doing a bit of activity on Twitter at the moment. So if you are interested in engaging with us on Twitter, use a search for the hashtag QOF QI, go to RCGP's Twitter account, which is @RCGP, and come and have a chat. We're posing questions, and we're trying to get a bit of discussion going, and just trying to generate, as I say, some discussion on these topics. So one last plug for the RCGP QOF QI page, which is rcgp.org.uk/QOF QI. You find other resources there we've produced earlier in the year, and links to a lot of what we've talked about today as well. So I wanted to wrap up as it's past, just to say once again, thanks to Mike and Liz for making the content so engaging. I learned a lot myself, and I hope you did too. I'd like to thank our colleagues, past and present, who've worked on the project, because we're all sort of collaborators in this, and there's been a lot of people who've worked on this who aren't on this webinar right now. So thank you to them, and finally, thank you for everyone who's attended tonight for joining us. And we're looking forward to seeing you in the next webinar at some point in the future. So thank you.